Very important topic, something that we don't seem to be discussing often. Can immune checkpoint inhibitors invade the sanctuary? So, I have quoted the sanctuary here, meaning the brain, crossing the blood-brain barrier. We know that brain metastasis is a common and rare complication, and I have been discussed about it already. And over one third of these patients develop brain metastasis over the course of their history of NSCLC, and traditional treatments have been RT and surgery. The concerns of using immune checkpoint inhibitor in brain mets were the traditional one was whether these drugs, being the monoclonal antibodies and the heavier molecules they are, whether they can penetrate the blood-brain barrier, and there is also a concurrent steroid usage that would be there for patients, especially with active brain metastasis, whether that impedes the efficacy of the immune checkpoint inhibitor use. And there is also a concern regarding the hyperprogression of brain mets. So we know that immune checkpoint inhibitor can have T cell infiltration into the tumor. So whether the hyperprogression of the brain met can actually make it more worse for the patient. So these were the concerns, and some of them are valid, some of them are theoretical. And the difficulty here was patients with brain mets were traditionally excluded from majority of the pivotal trials of immune checkpoint inhibitors, which actually brought these into forefront. And only about 6 to 17% of patients were enrolled in all the pivotal trials, and all of them invariably were either asymptomatic or previously treated and stable brain metastasis. None of these trials had any patients with active brain metastasis or symptomatic ones. But some evidence is accumulating of immune checkpoint inhibitor efficacy in this subset as well, with the real world evidence as well as small prospective studies. So what would be the theoretical rationale of using immune checkpoint inhibitors in brain metastasis? Mind you, I am talking only about the non-oncogenic driven non-small cell NSCLC, not the oncogenic driven one, which were adequately covered by the earlier two speakers. So brain is no longer considered to be an immune isolated environment. So the brain parenchyma does have microglia, which is derived from the monocyte macrophage system, and it is the innate immune system of the brain parenchyma. There will also be blood-derived monocyte macrophage system and T cells, which form the adaptive immune system, and they actively operate in the brain parenchyma. And it is also seen that brain mets with dense infiltration of tumor-infiltrating lymphocytes, they have improved survival compared to patients with brain metastasis showing low or absent TALs. And predominantly, the most important thing is the peripherally activated T cells, secondary to exposure of immune therapy, they can traffic into brain parenchyma, into the CNS, and this immune cell trafficking is perhaps more critical than penetration of the ICI molecule itself into the brain, across the blood-brain barrier. So the peripherally activated T cells, if they traffic into brain parenchyma, that is enough for them to cause the effect. The drug need not necessarily cross into the blood-brain barrier. The immune checkpoint inhibitors, typically they achieve 1% of serum concentration in CSF. Whether it is active or not, we don't know really, but probably the earlier point is more appropriate and clinically relevant. So with this background, let's see the data of individual ICIs. Pembrolizumab, the Goldberg et al. Trial, the phase 2 trial of previously untreated brain metastasis in NSCLC and melanoma, both were taken. The dose was 10 mg per kg Q2 weekly. The NSCLC cohort had 37 patients, so it's a small trial, and these are all non-driven mutation patients. The median follow-up of 8.3 months, and out of 37 patients, 11, almost 30%, showed intracranial response, and responses were limited only to patients with PDL1 positive staining. One third of these patients remained progression-free in CNS at 1 year, and another one third were alive at 2 years. So reasonably good data, prospective phase 2 data, and no treatment-related neurological adverse events were seen, pointing to the good safety. So this is a prospective proof of concept for the intracranial activity of immune checkpoint inhibitors in patients with NSCLC. There is other phase 3 data, but these were pooled analysis of pembrolizumab monotherapy trials, keynote 001, 010, 24, and 42. So we know that these are these are pembrolizumab monotherapy trials. The first two trials are previously treated NSCLC patients. The next two were treatment naive patients of PDL1 positive NSCLC. Pembro versus chemo. Out of 3,170, 293 patients had brain metastasis, and these were stable brain metastasis. In this cohort of 293 patients, the overall and duration of response, the overall response and duration of response were higher in the pembro arm compared to chemo, and PFS and OS were similar. The adverse event were lesser in the pembro arm compared to docetaxel arm, and there is no increase of immune-related adverse event in patients with brain mets compared to those without brain mets. So no new IRAE safety signals. The adverse event, it is more, pembro is more easily tolerable as expected, and the response rates were higher with pembrolizumab, though PFS and OS were similar. So this is in the pembro monotherapy pooled analysis of phase 3 data. What is with pembro plus chemotherapy, the often used combination now, pembro versus plus chemotherapy versus chemotherapy alone. So this is again pooled data from keynote 021, 189 and 407. So the total patient population is around close to 1400, and 171 were with brain metastasis, 1127 were without brain metastasis. If you see this median overall survival in patients with combination treatment in patients with brain metastasis at 18.8 versus 7.6 months, and the median PFS was 6.9 versus 4.1 months. If you compare the hazards for OS and hazards for PFS, they were actually superior for patients with brain metastasis than patients without brain metastasis, suggesting that the incremental benefit with addition of pembrolizumab over chemotherapy was much higher, seems to be much higher rather, in patients who had brain metastasis. So probably these were the poor to do subset which were getting much benefited with addition of immunotherapy. So, so comparatively, these were the overall survivals and progression-free survivals in patients without brain metastasis. So this is with pembrolizumab. What happened with nivolumab? The pooled analysis of 017, 063, 057, about 6 to 10% had brain metastasis patients. A pooled analysis, that is of these three trials, about 46 patients. This is nivolumab versus docetaxel in later lines of treatment. This is not in first line. The median OS was similar, 7.6 versus 7.3 months in checkmate 047, 057, and 5 versus 3.86 months in checkmate 017. So no difference in nivolumab versus docetaxel in patients with brain metastasis in the later lines of treatment in the pivotal phase 3 trials of nivolumab. CNS related adverse events were grade 1 and 2 only, very less, and the authors have only concluded that nivolumab has similar efficacies to standard chemotherapy with acceptable safety. So no specific signal to suggest that nivolumab benefits over and above chemotherapy in patients with brain metastasis. This is only in later lines. Atezolizumab, again a later line study, OAK trial, which we don't seem to be quoting a lot. This is in the later line, second line, randomized phase 3 trial. They included 85 asymptomatic brain mets patients. The median overall survival of atezolizumab was significantly better than docetaxel, 20 versus 12 months, with fewer grade 3-4 adverse events. So better tolerated and efficacy was better. And it was concluded that atezolizumab monotherapy was effective in. So these were all post hoc analysis of phase 3 prospective data of these immune checkpoint inhibitors. So this is the Kaplan-Meier survival graph in patient of overall survival in patients with brain metastasis and without brain metastasis. So a well separation of curves is seen in both arms. There is a pooled safety analysis of 1450 odd patients receiving atezolizumab across 5 studies for oak, poplar, birch. I don't know why all these were named after trees, but it is like that. About 80% of the patients were brain metastasis patients, 5%. The frequency of adverse events and serious adverse events were similar, and there wasn't across this pool subset analysis. This was a safety analysis. The neurological adverse events were similar, and adverse events were lesser with the patients with atezolizumab. So atezolizumab had longer overall survival. Yeah. So checkmate 227 again, nivo plus ipi versus chemo, the overall survival was better. So Nivo itself did not do superior, but Nivo plus EP combination seems to be superior over chemotherapy in intracranial response. There is some data for intracranial ICI plus cranial RT as well. So there's supposedly a synergy between those two. There is a meta-analysis of retrospective data which has suggested better OS with concurrent rather than sequential immune checkpoint inhibitor and SRS. So the rate of acute neurotoxicity was similar in patients who received SRS alone or in combination with ICI. So to conclude, brain mets, we know that it is associated with inferior outcome. In non-oncogen driven setting, immune checkpoint inhibitors did show some benefit with intracranial response as well as survival. Neurological adverse events across these studies, the small prospective and pooled analysis, they were not elevated. Pembrolizumab both in first and subsequent lines, atezolizumab in later lines, and nivo-ep in first line seem to have some favorable data in patients with brain metastasis compared to their control arms. And addition of SRS seems to be feasible and seems to be synergistic. But we badly need larger prospective phase 3 data in this difficult to treat subset. And we have, as it unanswered questions, especially in patients, what to do with the patients with active brain metastasis, maybe combined with SRS or something like that. So with that, I conclude and thank you for a patient hearing.